for RADT 201L. This is film identification for exams of the clavicle, AC joints, and SC joints. We will begin with the clavicle. Your clavicle exam, 2 projections, an AP and an AP axial. Both can be done on an 8x10 cassette or an equivalent light field on a DR detector. You want to include all of the clavicle of interest. You do not need the opposite side clavicle. So in this picture, your collimation can stop past the medial edge of the clavicle of interest. About halfway through the spine should do it. Anatomy that you will see: medial end, lateral end of the clavicle, conoid tubercle barely visible on the AP projection, your acromion, scapular spine, coracoid process, planoid, and the humeral head over here. On your AP clavicle, you will see the superior angle of the scapula superimposed through the body of the clavicle. An AP axial view, same type of collimation with a tube angle of 15 to 20 degrees, typically cephalic angle. The goal here is to project the clavicle above the superior angle of the scapula, which you can see here. The axial projection gives you a better view of the conoid tubercle. Here, there are ligaments that attach to the coracoid that come into play with AC separations. They attach to the conoid. Your AC joint is here. A distorted view of the acromion, coracoid, medial clavicle, and humeral head being projected up near the acromion because of the cephalic tube angle. Collimation-wise, we could tighten this up. Even with a cephalic projection, you should be able to align your central ray close to the clavicle, which on most people is prominent, even through clothing or easily palpated. You do not need all of this space over here. Marker placement, you have plenty of room above the shoulder off to the side for both AP and axial. Here's a right clavicle. Collimation is better on this shot. There is some pathology in here, fracture, AC joint, acromion, coracoid, superior angle projected quite a bit higher. Medial edge of the clavicle is visible. It's close, but we have all of it. So this type of collimation is ideal. This is not a shoulder series, so you don't need all of the humeral head. You don't need all of the patient's neck exposed. Axial view. Quite a steep angle here. Note how much space there is between the projected clavicle and the superior angle. Conoid tubercle visible down here. This illustration of a clavicle from Merrill's has some issues, as we've seen on the shoulder illustrations. On the model, you can see where the clavicle lies. So the central ray is pretty much along that. I don't have issues with the centering per se. It's all about collimation here. This collimation goes up all of his neck, a good chunk of the torso, and I'm not sure that it extends all the way to the jugular notch so that you would have the medial clavicle represented. So by all means, collimate significantly around the area of interest here. All in all, clavicle, routine exam, especially for kids who have fallen. It's fairly easy with just 2 projections, and your patient doesn't have to move. Just the tube and bucky need to be adjusted. For acromioclavicular joints, this is a rarer exam, but fairly simple to do. Typically 2 projections based on what your patient is capable of doing. This is a bilateral exam. Your department protocols usually will not have left AC joint or right AC joint. The radiologist will want to see both. So it's essentially positioned similar to a clavicle series, except you're getting both sides. So your patient is centered against the bucky. I recommend the more distance, the better for AC joints, particularly with broad-shouldered people. At 40 inches, you will have a hard time fitting the joints on the image, and even some very broad-shouldered people will not fit at 72 inches, but you can back up the tube and adjust your technique, and you may have to turn the key on the collimator, but the extra SID will allow you to fit more anatomy on the image. This image is fairly grainy, but you can see the acromion, the AC joint, clavicle on the right side, and kind of burned out over here. But the collimation is very good. Your area of interest for these exams are the AC joints. So you don't need a shoulder series. You don't need to irradiate the neck as much. You can collimate fairly tightly around the range of the clavicle, and you'll get both joints on there. Just like with clavicle and shoulders, in the corner is a good spot for your marker. You also want to label without weights and with weights. That's how these are done. Your first projection should always be without weights, because you don't know the level of injury. And if there is a severely separated AC joint, your weights may not be a good idea. Another AC joint projection. Collimation is pretty bad on this one, but you can see the pathology. This looks like a grade 3 separation. A little bit of rotation visible here. And you can't tell if this was done with or without weights. Coracoid, acromion, humeral heads. Note quite a difference in separation on the right side versus the left. Another AC joint image. You may think that we've clipped off anatomy because we don't have all of our acromions visible, but the joints are visible. But this is a case where a little bit more SID might help to see things a bit more clearly. Positioning using the model for AC joints. No angle, patient standing upright against the bucky, central ray going right through. Ideally, you should be able to put your central ray toward the elevated lateral side of the clavicles rather than right at the jugular notch, because the AC joints will be up a little bit and certainly collimate more up and down. You're going to want the full 17-inch wide field, so a 14 by 17 cassette put in crosswise, or a detector opened up all the way to the maximum lateral edges. There are 6 grades of AC joint separations. This is more for the radiologist to deal with, but if you do your first picture without weights and you see significant shift, you might not want to strap weights to your patient's wrists. So a grade 1 is just a minor sprain, partial separation of the AC joint itself. Grade 2, a little bit more severe. We've got partial separation of not only the AC ligament, but also the corticoclavicular ligament. Grade 3, we've got ruptures on both. So there is a displacement of the clavicle, typically going superior to the acromion. And grades 1 through 3 may not require surgery. The others are kind of rare. Grade 4, this is done in profile here because the clavicle actually shifts posteriorly. So there's not a great deal of radiographic difference from a grade 4 and a grade 3. You need a supplemental image such as an axillary projection that you would do on the shoulder, ideally done cross-table, to see a posterior displacement. Grade 5 is like a grade 3 on steroids. It's significantly displaced more superiorly. And grade 6, incredibly rare, almost never happens, even in the literature, but it is a clavicle that is displaced inferiorly and ends up below the coracoid, which is here. For sternoclavicular joints, a fairly rare exam, but typically a 3 projection series, PA and obliques. And looking at films, you should be collimated and centered right on the manubrium of the sternum. So you just need the medial ends of the clavicles. Your manubrium is here. And the easiest way to position for this, rather than have your patient facing the bucky, is if they're standing upright, turn them so that their back is against the board and center right on the joint. You should be able to either palpate or easily see the jugular notch. And the SC joints live right there. Once you've centered and collimated down to that area, simply turn your patient around. They are not going to change their height. So where you're centered in an AP projection, you can now put the joints closer to the bucky and get a better detailed image of those joints. Just turn your patient around. And you can keep them in that position, evaluate your image, and then adjust their rotation for the obliques. You need to do both obliques, an LAO and an RAO, anterior obliques, with a rotation of about 15 degrees, which is not much. Your goal is to move the joint that is closer to the detector off of the spine. So if your spine is here, we have rotated the patient LAO, and you're looking at the downside joint, which is, in this case, the left joint. And you will see that open, shifted away from the spine. So this is the medial end of your clavicle. This is your manubrium. This is the medial end of the upside clavicle, in this case, the right side. Your collimation should stay the same, fairly tight, and your centering shifts about 1 inch or 2 to the upside. You should not need to do much more than turn your patient and let the light field take care of itself. This is another oblique projection for SC joints. This image has plenty of problems. I hope you never produce one like it, but it is useful for showing the amount of rotation. This looks like more than 15 degrees because there is a significant shift away from the spine. You don't need this much. You can be fine with this much, and note how open that joint space is. Manubrium, because of the open collimation, you can see the body of the sternum. Right clavicle almost completely visible on this field. Left clavicle superimposed over the manubrium. You can tell this is an RAO projection because of how foreshortened the ribs on the right side are. It's because those ribs are turned toward the bucky and they become foreshortened. The left side, which pulls away from the bucky in an RAO projection, the left ribs are elongated. This is just a lot more field than you need, and it's off-center. It's pretty much centered directly over the patient's back rather than the area of interest. So don't rotate them very much and collimate down. Just centered a little toward the upside.